Welcome to the Prehospital Paradigm Podcast. I'm Scott Wildenheim. I have my colleagues here with me today. And to my right, I've got fire medic Caleb Ferroni. I got Dr. John Hill and fire medic Ray Pace. So today, guys, CPAP. We want to get into all things CPAP. There's been some changes in the UH sphere as of late. We've introduced some other devices. We've got some new disposable devices. There's some legacy devices out there. All things CPAP. All things CPAP is the name of the game today. So let's talk. Let's talk with the low hanging fruit. Let's talk about the stuff that's been the most recent, and we've released this disposable CPAP device. And I guess we start off with why. I mean, what's the advantage to
and disadvantages?
And disadvantages. Yeah, but let's start with the advantages though. Obviously it's disposable, right? So it's one and done. What are we picking up by going to a system like this?
Well, I think it's lighter for travel compared to emergent. My department uses emergent. We're very happy with it, but you're dragging the yellow box around with you. So departments that don't want to purchase the box, that is just going to be another added thing you have to carry. Now this comes fully packed in a little package that's going to give you the end title. It's going to give you the nebulizer with it. Whereas if you use emergence circuit, you have to purchase a T-piece.
Have all those individual pieces.
Yeah. So now I need an end title. Now I need a T-piece to add into the circuit. Then I need the nebulizer on top of that, where this is supplying everything. It's more compact. So I think that's why some people that don't purchase the yellow box switch over to the disposable unit. It's just easier. Firemen lose things, so this makes it pretty easy. Everything comes in one bag. I think a pro for both of them are that they plug into a 50 psi outlet, right? Compared to some of the low pressure units where that's going to screw onto the oxygen regulator. So the pressure's already been reduced one time now versus I'm getting true 50 psi into both units. So I think that's a pro on both ends, and I like both of these products equally. So that's just my take.
Yeah, the transportability is huge, right? I mean, if you've got even a little bit of room, a moderate amount of room in your first in kit, that can go in your first in kit. I know in my house, that's exactly the pivot we made. Is the CPAP was a treatment essentially reserved with the other devices that we've previously had. It was reserved for the ambulance, right? Mm-hmm. Now it's with the cautionary tale of I'm plugging that into my D cylinder. It's unrestricted flow. I gotta watch the clock because I'm draining that thing pretty fast. Not that the other products don't consume oxygen rapidly as compared to rebreathers, cannulas, our traditional oxygenation methods.
Going back to traditional, though, if you think about traditional facts, we were tethered to our squad because of some of the units we've had. Yeah. If you look at these are more portable. I do like the fact that they're replaceable because COVID and everything else. I mean, once we use it, it's gone. This, where we're continuing to reuse it, I get that it's not going back into the unit itself, but that's still there. This is completely replaceable. But we have to get out of the antiquated thinking that we are tethered to the squad with CPAP, because we're not. We're not. We could, like you said, bedside.
Yeah, you bring this bedside. Yeah, bring the therapy to the patient. I
thought that's what we were supposed to do.
I thought we were supposed to be mobile medicine, right? That was the whole point.
Yeah. And I think just easy use from that product too. I mean, both are easy to use in my opinion. If you open this unit up and you look at it, we put it together. So we have our filter, since Caleb talked about COVID. So there's my filter for that. With the emergent product, we do have a filter as well. A lot of people discard that, or they actually put it together wrong.
No.
And we don't want them to
but
do
it happens.
That.
It happens.
It does. And it's
easy to get rid of it.
It is. A lot of people want to lose that filter, and that's what's protecting the back of your ambulance right now.
That's what's protecting you.
Yeah.
Absolutely.
You're losing the circuit, but you're touching the box still. So I see the infectious control issue there. We want to make sure we're cleaning
that. One of the problems we're seeing, though, that I've heard about is why change something that isn't broke? I don't like that concept because this is what everybody's used to. This is what everybody's seen in most counties that we're running with for how long now? And then all of a sudden we're seeing this, and people are afraid of this. So how can we make people not afraid of this?
I think it's to go back to your point that this is what we've always used. How many people have serviced that unit? I'd ask everybody listening to that is, when's the last time you had
How
that
many times it's supposed to be serviced?
Correct.
So
we look at that, and you can actually mail that product back to Emergent. They will service it, completely recertify it, and then send it back to your department. I just did that at my department recently, and it comes back almost brand new. So it's like, how many times is that legacy unit, for lack of a better word, been serviced? But I think both operationally really easy to use. To try to sell people on this product as well is it comes out of the package. You have all the parts. You put it together. You're going to start at 5 centimeters of water, right? So my PEEP's going to be set at 5. If I want to adjust it, I mean, I turn the dial once. I'm at 7.5. I turn it again. I'm at 10. So I think for just a selling point on it is 50 psi is coming into the unit, which I firmly believe. I'm not a low pressure fan. That's just my personal take as a provider.
We were talking about this off camera before we hopped on here. The difference between high and low flow systems is that both of these are high flow systems. The patient can take essentially unrestricted tidal volumes, right? Yeah, obviously there's a cap somewhere where you run out of resistance. There's resistance in the tubing. There's resistance in the but that's a 60, 70, 80 liters a minute that they're going to be able to. If you have something that is making CPAP pressure, but it's making it with 6, 8, 10 liters a minute, that patient's inspiratory flow is inherently throttled to 6, 8, 10 liters.
Explain to me the pressure that you're talking about. Put it in layman's terms, because if I'm creating pressure and I'm talking about low pressure versus high pressure, what am I talking about exactly? Because if I'm plugging into the side of my ambulance, am I going to drain the oxygen faster? Am I going to run out quicker with something that's on a high pressure as opposed to a low pressure? So dumb that down.
I mean, the inherent answer is yes, right? Of course, if you have something flowing at 6, 8, 10 liters per minute, I mean, it's no different than if I have you on a nasal cannula, right, at 4 liters a minute. Well, of course, my oxygen source will inevitably last longer than if I have it, at 15 or 25 liters.
Absolutely. I think one of the things I'm trying to get at, though, is you got a brand new medic out of school, and they're going to say high pressure versus low pressure. High pressure, am I blebbing my patient? Because, I just learned about blebs. Well, that's not really what's happening here. It's not, when we're talking about high pressure versus low pressure, we're not really talking about interthoracic pressure.
We're not talking about interthoracic pressure. We're talking about, delivered, actually probably should retool that thought to high flow versus low flow is probably the better way to discuss that, right? Where this is unrestricted flow, not necessarily pressure.
Because the pressure you're actually talking about is what we're talking about
with the CPAP, yeah.
Yeah, so we're starting at 5 of water. That's the actual pressure that's even delivered into the airway. So that's what your pressure is. If 5 is not working and you go up to 7.5, 10, you have that ability to, but we're talking about the interthoracic pressure is always going to be 5, 7.5, 10.
Whatever you set it at.
Yeah,
whatever you set it at.
I think that's kind of a trigger word, though, that scares people when you hear high pressure versus low
absolutely.
pressure. That's why we need to bring it back to the basics and say we're not talking about interthoracic pressure.
I think all of our fire service colleagues can understand that volume pressure relationship.
We'll talk about the fire pump. Yeah,
exactly.
Are we using municipal water source? And if it's giving me such and such amount of gallons a minute, that's not exactly what I'm giving to the fire hose on the other side of things.
Correct.
Right, and then bring it back to the EMT level to talk about the fire ground. What do we relate this to? This is a positive pressure fan at the front door. When you're trying to ventilate a structure, this is positive pressure continuously.
And hopefully it's battery operated if we're not dealing, I don't want to push CO into the house.
Yeah, exactly. But that's the concept that I always try to, if I'm talking to an EMT and they're like, how does it work? How does CPAP truly work? How does it benefit the patient? I always talk about, it's like ventilating a structure. The fire's out. Maybe I just need to clear the smoke out. We're doing overhaul. It's continuous positive airway pressure. It's a positive pressure fan at the front door. So the other,
certainly in my own house, my pivot is we had these Emergent products years ago. What I found specifically for the CHF patients is that mask strap on that. Once somebody took the time to get that spider strap on, get get it up over
And
their head.
crank the heck out of it.
Yeah, and they crank the heck out of it, and they get it on there. Does the box works? It's 100% FiO2. It's 100% oxygen. It's super easy to use. The technical part of it was really the time-consuming part was really getting the damn thing on their face, right? And then once you did,
No more nitro.
you weren't going to take it off because I just
Correct.
spent 4.5, 5 minutes wrestling the spider strap onto my patient's face, and then it's like, okay, now it's time for my next nitro. Assuming I got the first one in, I remember to do the first
Assuming we're
one,
treating
right?
it for CHF also, though.
That's-
So
that's-
we have to go back to the indications,
I-
contraindications.
We'll get to that in a second, but I'm saying just our
Pros versus cons.
Yeah,
pro
pros
versus cons.
pros,
The mask on this is similar to like what you would find in a hospital. It's gel formed, BiPAP,
Yeah.
easy on.
You put it on
clips
like an
the bottom.
SCBA mask.
Yeah,
you
it's
just
very
put it on
easy.
and bring it around, right?
I
Not
think
so
a con
much
for
here.
that.
And the
Yeah.
other thing I don't like so much about this is you were spending a lot of time ratcheting this thing
Yeah,
onto somebody's
absolutely.
face and not applying the oxygen and not applying the pressure that they needed. And now you have people who are getting very anxious already, even more anxious because why am I not getting flow? Why am I not getting delivery? I can't breathe. What are you doing to me? You're making me worse.
Mm-hmm.
Well, this is kind of as soon as it's on, it's on. And I think that its application is so much quicker. And
Well, I guess with both these devices, if you're putting it on a patient, are you telling them to put it to their face and breathe first?
so should you be? And I think that
in an
yes, you
ideal
should
world,
be.
yeah.
Get comfortable with it
Yeah.
before I strap it onto you and
Exactly.
make you even
Yeah.
more anxious. But that goes back to good policy and good application of doing
Correct,
it.
that's
But
right.
patient advocacy.
But there is that small subset of patients, right? They're completely batshit crazy because they're hypoxemic, right?
Yeah.
They're an absolute wildcat, and not a bunch of times, but I've certainly had several cases where I basically had to hop on the patient and stick it on their face, and be like, "No, take a few deep
Take a
breaths."
few deep breaths. You're
And,
going to
and
like
then all of a
this.
sudden, you can just see the
But
the
I
color
have,
come
I have
back
also
in their
had
face,
patients who are so claustrophobic that they got scared to wear it, and it was
and they're tearing it off.
It's tearing off. What's happening though? They're becoming worse and worse, and eventually probably passing out. And I'm bagging them.
And you're
anyways.
chasing them with a BBM,
So,
sure.
And then at that point, this could have all been saved by maybe having them self-apply it first. Get comfortable to this. Are you comfortable with the way you're getting air? Getting out the air, because obviously if I'm putting pressure in somebody, you're exhaling a little harder than you should be. That's
Yeah,
why
'cause you're-
BiPAP comes into play and is a great tool, but we don't use that here. But I'm sure somebody will talk about BiPAP.
I wasn't going to because we're talking about CPAP. And we don't have it in our system. But that's what we do in the hospital side. But we have fancier hundreds, thousands of dollars of equipment to support that, not well-engineered plastic.
CPAP, and correct me if I'm wrong, I'm getting a constant pressure. That's the CP of the CPAP. All right.
Continuous,
Continuous,
positive,
constant,
yeah,
but it's
positive
constant.
pressure.
So when I set it to 5, let's say, I'm getting 5 in, and as I'm exhaling, I'm getting 5 in, and it's pushing
Correct.
against it.
Yeah,
so
you have to exhale
BiPAP,
against that
I might
5.
set it at 5, and then the exhalation, I might set it at 2. So it's not so much of a workhorse, but I think that it's a comfort thing at that point. And I think that's the biggest difference, right, between CPAP and BiPAP.
Well, let's take it back even one step further. If we're talking about a normal person that's taking a breath, when I just took a breath in, I'm generating a negative pressure inside of my lungs. So by generating the negative pressure, air from the outside flows into my lungs, and that's how I do gas exchange. As opposed to CPAP, what we're doing is we're increasing the pressure of that airway. So I take a breath in, it's forcing that air in, but then I have to take my lungs and the muscles around my chest to squeeze
Work
down to
everything back
force
out.
that air back out. The benefit of that is with the continuous positive pressure, and why we do positive pressure, depending upon which disease we're talking about. Like COPD is probably the most likely cause that we're going to be putting a patient on CPAP. So we're going to open up those alveoli that have been collapsed down and keep them open, and now I can do gas exchange through those now consistently open alveoli. And then if we're talking about fluid overload or edema or any type of edema in the lungs, as soon as you break that seal, you lost all that recruitment. You got to gain it back. And it's not instantaneous. Every breath you take, it's going to start to recruit more and more alveoli, but as soon as you take that pressure off, they can collapse back
And
down.
we call this sometimes flash pulmonary edema.
Yeah.
And this is one of the benefits of your nitro and being able to break that mask, because we got to put it somewhere. And somebody asks, well, where does it go? Does it just disappear with the nitro? So who can answer that one?
Where does what go?
Where's the fluid going if I'm using nitro?
Where it belongs.
Yes.
Which is,
Yeah. All we're doing is rearranging fluid. But back to your point. What you said as far as it's going to help with the inspiratory. By conversely, does that mean that patients with primary exhalation diseases, like asthmatics, are going to have a harder time with CPAP? Is there a time and a place to put them on CPAP, and how far do we let them get down the rabbit hole, if you will? At what point do we say, hell, bronchodilators are my primary response here, right? But when does CPAP become applicable in that case where you have a primary exhalation disease? So when do we transition there? So I've got this horrid asthmatic, and currently their SATs are okay. Work of breathing is absolutely terrible.
Yep.
Because they're getting air in okay, but they're not getting it out or trapping everything. You've dumped a couple aerosols on them, and maybe now we're thinking about stabbing them with some epi or setting up some mag. All right. Is that a case for CPAP, or do we let that patient go with the bronchodilators and follow the pulse ox and wait for him to desat? Where's it?
So I like to keep it simple.
Yeah.
If they're in any form of respiratory distress, unless you're obviously dealing with a tension pneumothorax, CPAP is always going to be your go-to. So for the nerds, looking at data, work of breathing by CPAP or any type of non-invasive positive pressure, and that can be a lot of devices, but in this, what we're talking about is CPAP, you can reduce your work of breathing by about 60%, and then you can reduce your dyspnea scores anywhere between 29 to 67%. I'm a big proponent of anyone in respiratory distress is going to go on some type of positive pressure ventilation, regardless of if it's an asthma attack or if I think that this is flash pulmonary edema, if this is fluid overload, if this is COPD. Because it's going to, no matter what the disease process is, it's going to make the work of breathing much easier. You're going to give a lot of relief to that patient that's breathing. And then when we transition to the hospital side, then we can use bi-level support, which offers even more benefits in certain diseases, but not always, actually. I like doing early CPAP before I even do breathing treatment, and I'll tell you why. By having this positive pressure in and opening up and recruiting more alveoli, I can allow more air exchange, and if they're going to be taking in these aerosolized treatments, they're actually going to get farther down into the lungs and have a better effect. Sure. So I kind of describe it to everyone is because we have this positive pressure, it's literally pushing that down into the lungs. Instead of most people that are in extremis, if they're breathing really quickly and they're not taking a lot of tidal volume, they're actually only ventilating the dead space of the
airway, right?
Of the airway, and that's not going to do any good. We need to get it down low into the bottom of the lungs. So when you're doing your assessments on these patients and you're listening to their lungs, you're like, man, I don't really hear anything. Because they're not moving air down where you're listening inside the lungs. They're just moving it through the large airways, which aren't doing anything to do anything.
Yeah, there's no gas exchange happening.
Correct.
At basically everything north of the carotid.
And to your point, sometimes I think that we get. Let me bring it back to a call that I heard about. So I reviewed a call, and somebody gave aerosolized treatments a couple times, and now they're hearing wheezes. And I want to say, that's good. You're doing something.
Yeah.
You're doing
That's
something
improvement.
good. Give more.
Yes.
Right? And at this point, they're like, oh, my treatments aren't working. No, they are.
Patients
And now you're
worse.
loosening them up enough that you're actually hearing the
Yeah.
wheezes. So that's
you
a
went
good
from
start.
no air movement
Silence.
To some.
Silence
to more,
is scary.
to some.
Silence
So
is bad.
you want to give them the cross and say, keep going. You're doing the right thing. You're
Yeah.
not doing the wrong thing. And this is a basic step, and you might assist somebody with their MDI or their albuterol at home, and now you're hearing wheezes. Do it again.
And,
you're doing
and
great.
you touched on this a minute ago, Ray, and John. We can continue the aerosols, or administer the aerosols while we're doing the CPAP.
Absolutely.
Oh, yeah.
And you
It's
know,
easy.
That's preferred.
the disadvantage that you spoke of earlier is you have to remember to throw a T-piece in
Correct.
with your emergent circuit if that's what
Yeah.
you're using, right?
Well, I mean, you could break the seal just like you would for the nitro to put the T-piece in, but you're right. It's got to be there to
You
use
still have
it.
to have it. You have to, and you're doing your truck checkout. It's something very easy to overlook, especially if like in my house, I just don't believe in T-piece nebulizers because I wind up getting more of the drug than
Sure.
than the patient does, right? They're FaceTiming their boo or whatever, and they're spraying it in my face. That's excellent, right?
Smoking
I
the
too.
peace pipe.
Yeah, I need you to get this. So I'm all in neb masks. So it would be really tough, if I still had that. I would have to package it with that, or else they wouldn't have it.
we
it's part
tape
of
it to it.
Yeah, exactly.
tape it to
Yeah, we
it, open
tape
the
it.
bag,
We tape it
throw
to the circuit.
Yeah.
That's what we do at our place. I mean, our place takes just over 4,000 runs a year. We have 2 emergent circuits on each squad, and we tape the T-piece to it. We have nebulizers in the house bag, nebulizers in the O2 bag, nebulizers on the shelf. So, we have the ability to put CPAP on the patient immediately, start to treat them, and then if you want to get into giving a duo-neb, great. This setup on the Pulmonite O2 Max is kind of nice. It's just
baked
streamlined. It's there. It's nice.
It's baked in.
I uncap it, and then as soon as I put my
One-way valve.
nebulizer in, it's going to open it up, and then now I'm going to be able to give my treatment. So it's nice.
It comes with the neb.
it comes with
it.
it.
falls in your lap when you open
Yeah.
so it's a nice reminder.
Yeah.
And then from a protocol standpoint, I mean, again, keep it simple, stupid. Basically, anytime CPAP is called for a respiratory, not a traumatic event, an aerosol's indicated. So
Yeah,
it basically
general, yeah.
it basically falls out in your lap.
And I love the road that you took with what you said about, I mean, that goes for every level of provider care. If you're getting the CPAP on first, you're getting that alveolar recruitment, you're getting more treatment.
Yep.
So that is a beautiful path to follow. And I think that going forward at Con Eds and stuff, that's the exact words I'm going to use. It just makes sense.
So
Get that recruitment, get more treatment where it needs to be.
From
Start
a
with
medication standpoint, we only typically, if we're talking about doing nebs, which is what we're giving to all these patients, right?
CPAP. Albuterol Atrovent, yeah.
Yes. Is that we only give 2 treatments, so 6 mLs total. And there's no benefit shown in studies that for above that. No data behind this. If they were given any number of aerosols before CPAP went on, I don't count them. I restart my count with CPAP.
Oh, fair enough.
Yeah. Because
So that
once
way,
the
if they got
alveoli are
2 and then
expanded,
got it,
you have more room for the
And what's
gas
the
exchange
half-life
because
on your albuterol
Yeah.
and Atrovents? It's-
And restate your position on the 2 breathing treatments, only giving 2. What was the?
so I can't kind of tell you which study it was, but
Yeah, I mean,
I'm not. That's what I was looking. I
Yeah,
don't-
from a protocol standpoint,
protocol
there's no
standpoint.
cap, right? And
Right.
and
well,
that gets
when we run out,
yeah, right, exactly. Is it empty? Okay, yeah,
I might make
guess.
some epi and make some racemic,
But the point that often gets overlooked here is there's 2 boxes for DuoNeb, but the second box nobody reads the one important letter in there, which is making repeat aerosols plural. So by protocol there's no cap. Your point on 2 treatments.
So for doing nebs, and it's not the albuterol, it's the ipratropium in it. Is that there's no benefit to giving, if we give 2 doses of it, you've gotten all your effect from that medication. Giving a 3rd or a 4th or 5th doesn't really buy you anything. Sometimes in emergency medicine we'll give 3 of those treatments because, maybe one's a dud and we'll throw a 3rd at it.
Sure.
But the data says that only 2 treatments is all you need to get that extra 15% benefit of bronchodilation from that drug, but you can pound them with aerosols all day long.
Absolutely. And
There's some
when-
caveats in pediatric medicine, but from an EMS standpoint, from medicine in the field, you guys aren't going to be transporting long enough to worry about if someone's been on continuous albuterol for 6 hours and
Correct.
the tachycardia that comes with that. And
So that's the worry I have heard from departments I've done lectures for and such is I'm giving albuterol, giving Atrovent, my patient's getting tachycardic.
yep,
Yeah, they are, and that's okay though.
They're
that's
in
okay,
extremis, though. I would expect that's going to be their physiological response.
But I don't think with each treatment comes higher elevations of tachycardia. I think that that's the worry, though, is that I'm going to put them in an SVT or something. It's like, no, I don't think that's the case.
More often than not, my patient that can't breathe
is tachycardic because they have corporal pedal syndrome and they're spasming.
Yeah, I get them with a respiratory rate of 32, and and a heart rate of
130,
140. Yeah, to your point, I've given lots of treatments. I can't say that I saw people continuing to trend down. There's always an outlier. I'm not saying that outlier doesn't happen, right?
Yeah.
So it's easy on, easy off at that point.
Exactly.
You had to.
And more often than not, by the time I drop them off at the hospital, that rate settled down. Does it go back to Does it go back to their resting heart rate of 72? No, it does not. It's still a sympathomimetic and an anticholinergic together, right? No, it's never going to settle back down to.
But I think that we need to get rid of that worry that we've put people in SVTs and so. I'm not sure what the worry is there, but it's okay.
Well, I mean, if we're
it's
going
a
down,
response to the medication.
it is. Well, it can be a response to medication. It can be a response to physiological change because we are making changes inside the lungs, and maybe now the heart's actually getting more oxygen and pumping better and having a better cardiac output. But also think about it, if you're talking about these patients that are in true distress, our next step is going to be epi. Do you care if we're going to be giving epi to these
nobody
patients?
blinks.
No one cares
nobody
about
blinks
that.
That's okay.
Yeah, that's fine. But the albuterol's causing the heart rate to elevate a little bit. But
And you have to think too, so like to your point, back to that, to kind of kill that stigma, is how many breathing treatments did they do before they called 911?
Well,
right?
that's
How many times did they hit their puffer?
Yeah, did they hit their meter dose inhaler 5 times?
Is the medication still active?
Correct. Is it good? Is it out of date? Do they leave it in their car in 90-degree weather? And then what's the?
But then, how many substitute breathing treatments, their menthol cigarettes, did they take before that as well? I mean, and this all plays into. It's just. What are we going to do? Where are we going from here?
Without turning this into a complete discussion about pharmacology, which inevitably every one of us wants to do because we like talking about medications. And back to CPAP in a second, but your point, they've hit their puffer 100 times, then called us.
Yeah.
Right? My trigger, my personal practice, MAG came way up on my treatment list, right? So they hit it a bunch of times. All right, CPAP, albuterol, cool, but they've already failed us. They've already failed us in pathomimetic a bunch of times.
Most patients don't have DUANEBs at home. They don't have the ipratropium, right?
Yep.
So that's why, hey, okay, so you called us, you're short of breath. Yeah, they tell you, I'm using my nebulizer, I'm overusing my nebulizer, I'm overusing my rescue inhaler. Yep. I cracked this one today and now I'm empty and I've gone through 120. Yep. That's when that's why they need the ipratropium.
What is that doing? What is the ipratropium? Just so that we can put it in layman's terms. I mean, I've heard it been called a drying agent. I've heard it been called bring the cough out agent. So
it's a bronchodilator. And you can only get so much from albuterol. Albuterol is going to cause as much bronchodilation as it can. We can see up to a 15% extra dilatation with the ipratropium. And that's why we use it in this situations. We're looking for that just a little bit extra. But remember that if we have an airway, and as we increase that diameter, you're actually getting, 4 times? You're not getting if I increase by 15%, I'm not getting 15% more air. I'm getting an exponential growth in that air as the diameter of that tube increases, right? So that extra 15% is way more actual air getting in, more gas that the patient's able to exchange.
Right.
But this is also a reason why it's not usually prescribed as a take-home.
Correct. Occasionally we'll see it. Occasionally for the really bad COPD patients that are really good. They're really good patients. They know what their disease process is. Those are the patients that I will sometimes write for them at home, or their pulmonologist has decided that they can have it at home just to stop them from coming to the emergency. They don't want to come in.
They just need that boost.
They just need that boost. And then they call you and say, hey, I've already done my DUANEB treatments. You're like, all right, go time.
And these are the patients, we all have them. If we're still running ambulances, I know I am, that we know when we get called there, this is the real deal. We're going to get there.
Yep.
There's one particular I can think of that I've intubated twice now that I've been there. And it's usually they're calling at last minute and they've run out of something or, and we know it's bad. We have to be on our A game when we get there.
Yeah, not to piggyback off the intubation thing. Why are we pushing this? Why are we using this
To get rid of intubating.
We don't want it. We don't want that patient to go to the emergency room. We don't want that patient to get intubated. Right? We're trying to avoid that. So
to your point,
be eager to utilize this product to try to avoid
faster.
intubation. We don't want the patient to get intubated and then they go to the ICU, right? And then the risk for ventilator pneumonia goes up, increases. And it's just we go down that sepsis path. And that's not good for them.
To put numbers to that, by putting a patient on CPAP, you're going to reduce their risk of intubation by 65%.
Early CPAP.
Early CPAP, right? You're going to reduce if they end up staying in the hospital, which if you're putting on CPAP they likely are. You're going to reduce their stay by about 3.5 days total.
So this is one thing that I don't like, and I've heard a bunch and I've seen. I've got somebody on CPAP. They've done beautiful for me. And they're tolerating it well. Their numbers have all come up. They've relaxed, gotten rid of the carpal tunnel syndrome. We're there. Their numbers look great. I get them at the bedside of the ER. The nurse takes it off.
Yeah.
And I walk back in after I've got done getting my signatures, and I hear respiratory being paged to the ER. I hear code to the ER, and it's like, what happened? Well, now they're intubating this patient. Why can't we have this better handoff care where I go to the ER and I say, look, I fixed them, keep fixing them. But
sure.
Instead, they rip this thing off and I see them on a cannula. Well, their stats were 100%.
Yep.
They don't need it.
Everybody looks good delivered on CPAP.
Oh.
Yeah.
Of course it is.
How do we break that chain of horrible chain of command?
I think a lot of that is on the phone call, and that is on the medic, but it's
That's
also
on us.
or the EMT.
That's a lot on us.
And that,
EMT
I
or
agree with you.
paramedic.
It's on
This
us.
is-
It's a lot on
It's
us.
bad hand of care.
Yeah.
Yeah, it's look. You don't understand. This patient was an absolute mess when I got him.
He looks great now.
Yeah,
Because I
this
fixed
is
it
way
with
better.
this.
Fixed it, yes.
You need to listen to me, right?
Yeah, it's hard to paint that bad picture when they look great, right? Because we utilize the tools.
The numbers are great.
But also,
yes.
I think this is where pushing that nitro comes into play too for us. We can help this a lot, and we'll go into that I'm sure a little bit
Yeah,
later.
we'll
But
dive on this.
for now, how do I hand off that care to say, hey, you need to continue on this treatment path I've done? This is why. It's scary.
So
I think you have to front load it. I think it starts with your call into the ER. My personal opinion. I think it starts with your call into the ER. Hey, I'm X squad bringing you a patient that's on CPAP. I need you to page respiratory now, right? So when you walk in, then hopefully the ER physician hears that, knows that, or you got a good charge nurse that says, okay, so when you walk in and we slide them over to the bed, and then respiratory's there, right? And I see the biggest success from that standpoint because they're coming right off of our CPAP, and then they're either going right onto
Right
a
on
BiPAP,
theirs.
Yep, right
or
on
they're going
BiPAP,
right onto a
right,
CPAP again. And the respiratory therapist is there understanding, okay, they did this, yeah, they look great. I need to maintain this. And usually, I've never really had an ER physician go against that, or say, oh, I don't want respiratory, go back, right? So I think that helps the continuation of care is trying to front load the conversation, just pushing it on the phone. I'm requesting respiratory when I arrive. It gets them down because, how far away is that respiratory department from the ER too?
I like what you said
they're
about
doing 100 other things, right?
Yeah.
about the physician usually isn't our issue. It really isn't. And one thing that I want to try to bridge when I teach the medic class, when I do CEs, is we cannot be afraid as a paramedic, as a basic EMT, as an intermediate EMT,
As
of
a
the
patient
physicians.
advocate.
As a patient advocate of talking to the physicians.
Yeah.
A lot of times I see that the paramedic or the basic will walk in and be like, talk to the nurse just fine, but when the physician comes in,
I'm going to give my report like
yeah, I'm
this.
going to give my report like this and walk away.
uh,
What are you
I-
afraid
I
of?
did things. Yeah.
I'm not particularly afraid of Dr. Hill.
yeah.
But if I express, but if I express to him patient advocacy and I say, this is why I did this, I think that you're going to have a better outcome. But we need to stop not having this bridge between Garlisi says it best, Dr. Garlisi, we're physician extenders.
Right.
And that's more what's happening with the paramedicine culture. And we need to be able to talk to our physicians as peers and say, this is what I did. here's my continuum of care, because that's exactly what it is. But if we're not doing that, if I'm giving my handoff to the paramedic there, and I'm, hey buddy, I haven't seen you in a couple days. Oh, here's my patient. There they are. You got my squad phone report, right? Cool, I'm out. That's not adequate.
Totally inadequate.
That is totally inadequate. We need to be doing better, and so do better, man.
Let's talk about this. First, I think report's going to help. If you say, hey, I need respiratory at bedside, that's one thing. So I have so many thoughts right now. Between these two devices is with the yellow box. That's a device that belongs to the squad. You guys have to hang around.
Yeah, we're getting it. I'm taking it. And if I don't, my chief will tell me.
Yes. Not only your
You're
chief,
afraid
I'm sure
of
other
him.
guys.
He's going to chase you down. He's the guy to be scared of.
So now you're leaving equipment with us that you guys know how to retrieve. Both of these devices I can plug into the wall and just go, and I can leave patients on both these devices. The benefit of the totally disposable system is you give report, I can leave this patient on this device, and you guys can walk away and don't have to wait to retrieve your yellow box, right? So that's a benefit. That's one of the benefits of just a total disposable system. On the second side, if you're calling a report and we've had this terrible patient, we've now stabilized on positive pressure CPAP, calling in saying you want respiratory, because it might be that I don't have respiratory there. Or in my shop, we had an issue where you guys in our system standardized on this one connector device in all the ambulances that didn't match up with my hospital. So I had to buy adapters for my hospital so that way I could plug your equipment directly into stuff. And now we can do that, but it may not be that way. But ideally, we've got our...
Amusingly, I happen to have said problem right here to discuss later.
Yeah, so on my wall, I have my high flow 50 psi screw-on connector.
DISS.
Yep. Mm-hmm. And no,
but you can
break. You can
break it off. And you can go right to your wall.
You can break that.
Yep.
same thing there.
Same thing there.
That needs to be discussed, absolutely.
But it's much easier to have a quick connect than you just plug into the wall, right?
Absolutely.
Yes.
So when I have patients that come in on this, I'm like, oh yes, plug it right in the wall, and I let them sit there until respiratory can come down with the expensive BiPAP machine and get them set up on BiPAP.
Blood gas and everything you guys do.
Yeah, all the things are there. I'm happy to leave them on this. And I think that so if I'm in the room and I hear this, of course I'm going to leave them on. I've got great nurses that they don't rip off the CPAP. However, there are times where if that's not communicated to us great, like you guys really don't understand, like this person was a step away from having to be intubated and meeting his maker, they should be kept on this. We do, at the same time, want to trial them off. If they look great, we're like, let's trial them off and see what happens. And to our detriment, maybe we trial them off. Oh, they're doing good. I walk away. I even come back 5 minutes later, and now they're not responding, right? So if we're doing that in the hospital, or if you guys want to be interactive with whatever treatment therapy you're doing, you need to see what the change is going to be, and the change may not be immediate. It might be a few minutes down the road. But when I see the patients come in and they're breathing comfortably on this, we switch them over to my stuff. I go reassess them a few minutes later, and they're often like sleeping in bed because they're very comfortable on this.
Absolutely.
I've done my job.
They've run their marathon without being
exactly. Yeah.
So now
exactly.
they're tired.
Yeah, they're tuckered out.
They could breathe. They're happy.
They're breathing.
They can rest.
I just want to circle back to one point about connectors, right? And I don't want to make this a big thing, but
we could do a whole podcast on connectors.
But no, this absolutely needs to be said, right?
So the quick connector will come off, right? And I want to make sure that people understand this does not go on the oxygen tree.
What?
Right? This only goes on
shockingly
high pressure. Right, this unit requires 50 psi coming into it. Right,
Yes.
So you brought it up, and it'll fit too.
It will absolutely fit.
That's a little bit of the danger of this unit. Is this
either of these devices screwed onto your flow meters an absolute no-go?
Yes.
Yeah, I mean,
so
it's standardized.
This will go here, and that's not what we want, right?
Absolutely not.
We want high pressure into both of these units, whether you're using emergent or using the Pulmonine O2 Max. And I think a lot of people get confused about that, right?
High pressure, unrestricted flow.
Correct.
There's the...
Right, because if you think about, it's like an SCBA, right? So Caleb, back to, let's use the fire analogy again, right? Your air pack has two regulators. It's first stage and second stage.
A high and a low, yeah.
A high and a low, right? So there's your flow meter. You're restricting that already, and that's not how these units are made. and that's not what they're going to respond to. It's okay to unscrew that and plug into that 50 psi outlet, and you're going to get the correct
One of the
psi
problems
into
is,
the
though,
unit.
is that it'll still make a noise. It'll still get air,
Correct.
but it's just
it
not.
still gets air, but it's
So you
not
think it's
giving the
working.
patient what they need, right? So
Yeah.
then they're like, oh, they're on CPAP and they're doing so good, and then now they're struggling. Why is that? Do I have a unit issue? No, we have a supply issue.
And to your point, I say we all standardized. Yeah, I don't think everybody standardized,
For the
but
most
it's pretty
part.
close. Yeah, and that's that Ohio or OMEDA connection
Yep.
that it's dash dot dash.
Yeah.
And-
So
and
the
that's-
question you're going to get is, well, if this is plugged into that, it's not plugged into that. So that's where the difference is. This is not.
Yeah, that
plugged
is not
in
special.
there.
That's just an
Right.
adapter.
Right.
Yeah.
But if your wall plate after you dump the flow meter off the wall,
Correct.
looks like that, then that device will connect right in.
Yep.
It's got the adapter built
Yeah.
right in.
So,
It does.
yeah.
And they make multiple adapters
And
for
likewise,
different.
yeah. I mean, this has a it's steel and plastic, but that's got a quick disconnect on it. Same as that. Now on your portable, right? That's DISS threaded. You can thread that right on there if you don't have that connector.
Yep.
And then what you were talking about is your hospital stuff probably looks like that. And that's a Chemtron connector.
Yep.
And none of that stuff will fit in there, right? So, and even I've come across ambulances that have Chemtron connectors. So I guess it's worth the exercise to pay attention. If you pick this stuff up
Yeah.
at the hospital and you've got Chemtron connections,
Yeah, it's not gonna work.
And you're
Correct.
you're not going to be able to plug it directly in. So.
And those are easy things to fix.
They are very
they're-
easy things to
They're
fix.
easy. They're cheap to fix. I want to
Have
say
the
those
have the
those
adapters right here, right.
are like
Yeah.
$17. I think this one, Pulvinine. I think you could spec it if it's the OMEDA connector. If it's a different connector, they sell them with all different connectors that'll fit your unit.
And if all the departments around you have the same connector,
It should be
you can even change that.
standardization.
You can change that wall plate out. It's
not hard.
maybe $50.
Yeah.
But
It's money.
Yeah.
it's still money. Now, understand that.
So back to the point before, though, how do we bridge the gap between providers and being afraid to talk to you?
Well, you guys should never be
face-to-face?
afraid to talk to us.
So, in your discussion, it was your practice, and obviously we work together. I can walk in and be like, "Hey, man, look, this patient's a train wreck.
Yeah.
We did things. You probably should continue doing things. They're really sick." We can clearly have that level of dialogue, right?
And also, you've
But-
built rapport where he knows if you come in and say, "This guy's sick," this guy's sick.
Yeah, 9 times out of
So-
10, I'd be like, "Yeah, he's okay. We got him straightened out, and he'll be fine." But that rapport thing aside, there's a mean person somewhere that
Sure.
we're eventually going to interface
Yep.
with, and I guess to your point is we also have to suck some of that up and understand everybody is
Everybody's
not
human, and we all have bad
everybody
days.
is not EMS minded. People have bad days.
So, okay, let's say you give that report and then you're giving bedside report. I think that there's keywords you can say, especially like giving history, like saying like, hey, this patient's been progressively short of breath for the last 3 days. They're well known to us. They only call us when it gets this bad, and they end up being in the hospital for 7 days, 5 of which are on BiPAP. We got there, they're speaking in
intubated
1
4
word
times.
sentences.
You're painting a great picture.
Yeah,
right?
so paint the picture to me. You're like, oh crap, they, as opposed like because that might be a travel nurse that has no idea who you are, who that patient is. But if you say, hey, I know this patient, they only call when they're sick, and when they come in, they're this garbage fire. Luckily, they're stable right now. They end up staying in the hospital. Like paint that picture to say like I would leave that on, and if again, be that patient advocate. If you see them rip off that mask, maybe just hang out in the room and work on your documentation to, if that nurse leaves and they start to decompensate, you go, hey,
Yeah.
patient's going downhill. You might want to put them back on CPAP so they don't arrest.
Years ago, I mean, I had a case where it was a tracheal cancer patient, and we got the call she was stridorous, and it's like, I mean, it was all kinds of scary.
bad.
We had thrown some nebulized epi at her. We didn't have her CMIC at the time, and I mean, we had her prepped. Had the quick trach out. I was like, oh God, like half of me's excited I'm going to do this. Half of me's terrified I'm going to do this. But that aside, we did not wind up doing anything with the neck. We rolled into the hospital, and the nurse was trying to put us in a hall bed. I have rapport with this nurse, and I'm like, no, we need a recess room. This patient's bad, and she's not listening. No, we got to start in the hallway, and I walk down to the doctor. I'm like, sleepy stridorous tracheal cancer patient, and they just jumped up and like, what else needs to be said, right? And they're like, oh, we're starting. He said, no, put her in a recess room. And it's a perfect example. I just had to, I'm not getting through to this person, right? They're having a bad day. They're not hearing what I'm saying. I've seen them I've already seen them probably 4 times a day because it was a place we transported to every single time. And all the other stuff I brought them the day and the day before was kind of BS. All right, this is the super sick one, right? And again, patient advocate, you got to pivot.
You have to.
Grab them.
But that comes back to whose fault is that? It's both of ours. It's me and the receiving hospital. Patient advocacy doesn't stop. It's a continuum of care, and that's what it needs to be. So I need to be damn sure that whoever I've released care to understands everything that I understand to this point, and that's where kind of an echo system works. Hey, do you get what I'm saying? I get it.
Yeah.
All right.
Yeah.
And I think that'll help with a lot of the handoff problems that some of the people are afraid. I don't like the word afraid, but I think that's the best
There's some
word to use,
trepidation
of talking to somebody of higher care, and we can't be. It's a continuum.
Well, I mean, that's our specialty is out of hospital medicine.
It's a foreign environment to us.
Yeah. It's foreign. We're coming into the hospital, but likewise,
Yeah.
you guys would be fish out of water if you came out, and we're doing stuff on the side of the road.
Yeah.
Does the medicine change?
No.
Not all that much.
No.
It's more operational than anything.
Most docs haven't intubated in a hallway or in a hoarder space
Or upside down in a
Upside
car.
down. Yes.
Exactly. And most nurses haven't even seen that situation either.
Sure.
So you guys need to be our eyes and ears in that situation. And this goes beyond just CPAP to be like, you're bringing a patient in, you have concern for like hoarder conditions. We need to know about that so we can have safe discharge plans.
There's this great exercise I like to do for the medic classes. I have one group leave the room. The other group will reenact in front of a couple other students a scenario. Those students document it. They leave. They give their documentation to the group that was left. They play it. And then the group that reenacted it the first time gets to watch what they played out based on their documentation, and it's usually a horrible show.
Sure.
So what I like to call it is you need to document it like a script play,
Yep.
that it can be reenacted perfectly, and then be able to sit on a witness stand 30 years from now, maybe not 30, but 10 years from now, and
2
play
years.
it out just the
Wow.
same way. Yeah.
Yeah, 2 to 3
So-
years is not unreasonable or
Well,
unheard of.
I mean, that if you're
And are you going to remember it if you're running 4,000 calls a year?
No.
Yeah.
No.
It's hard.
But
So-
that takes time to write a good narrative.
It does, and that's.
And-
but we
and-
have
and
to. And your continuum of care is. Are you guys looking at our reports?
I'm
Sometimes,
the,
yes.
I'm the voice to text guy. You're right. Watch this.
Oh man! Until your partner
I'll
sits
dic-
next to you and
I'll
starts.
dic-
I can say whatever I
I
want
can
now.
do-
It's going to pick it up.
Yes.
I spent a lot of time deleting explicit material out of there, but
I'm a copy paste guy, and one of my examples is I've watched the physicians do their dictations, insert my normal narrative, right, and I do the same thing. I copy paste into my narrative, and then I have question marks where I know I need to refill.
Sure, absolutely.
So
Patient
almost
specific
every
things.
one of my narratives are almost identical, except pertinent information based on the patient I'm dealing with. So that way, if I'm ever called to court, I can guarantee you, one, I know it's going to be my narrative because I look at it, and two, exactly what I'm looking for. So why reinvent the wheel? If we have a copy paste option, if you have a dictation option, use it.
Absolutely.
Use it.
Yeah.
But document is key. Everything. That's patient advocacy. That's handoff.